dengan ini menyatakan kemerdekaan Indonesia. Hal-hal yang mengenai pemindahan kekuasaan dan lain-lain diselenggarakan dengan cara saksama dan dalam tempo yang sesingkat-singkatnya. Jakarta, 17 Agustus 1945, atas nama bangsa Indonesia, Soekarno, Hatta.
Silakan Irma.
Well, thank you, ladies and gentlemen. Next, we will play you the Indonesian national anthem and PARI marching song. So for Indonesian radiographers only, please take an upright positions. Thank you.
Radiografer Indonesia bersatu padu di dalam cipta, tingkatkan kualitas sumber daya manusia, kuasai ilmu dan teknologi, berjuang untuk capai cita-cita masyarakat sehat sejahtera, berlandaskan pada Pancasila dan Jaya dan Undang-Undang Dasar 45. Sing-singkanlah dengan bajumu, berikanlah pelayananmu, bersujudlah pada Tuhan agar limpah karunia-Nya. Kobarkan semangat pengabdian, wujudkanlah karya-karya nyata, berjuang bersama, tingkatkan pelayanan bagi kesejahteraan bangsa. Radiografer Indonesia, maju dan kibarkanlah panjimu. Doaku selalu pada Tuhan Yang Esa agar PARI tetap jaya.
Well, thank you. I think the local content is over, so I will hand it over to Pichi again. Pichi, the time is yours.
Thank you, Irma. Hi, everyone from Asia and all over the world. Hi, everyone from Asia and all over the world. This is Asia CPD, online continuing professional development platform for Asian radiologic technology societies. Hosting the 16th CPD Asia is the Indonesian Society of Radiographers, PARI, Perhimpunan Radiografer Indonesia. And I am Peachy Luna, your program host. We are again grateful to our sponsor, VT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search PARI and VART channel. So you can join us live or watch again a replay using these YouTube links. Now, to formally start the program, please welcome the President of the Indonesian Society of Radiographers, PARI, Perhimpunan Radiografer Indonesia, for his opening speech and welcome remarks. Ladies and gentlemen, the President, Dr. Gyek Sugianto.
Okay, thank you, Peci. Good evening, everyone. Dear all presidents, delegates, speakers, and colleagues. On behalf of the Indonesian Society of Radiographers, PARI, I would like to welcome you to the 16th CPD ASIA. This is the third time for PARI to host the CPD ASIA event. The topic for this event is pediatric imaging. Radiological imaging is a powerful diagnostic tool for pediatric population, but there are a number of challenges when performing procedures in pediatric patients compared to adults. We hope this topic will interest you and give new insights for all of us. The total participants we have registered in this webinar are more than 1,600 participants. Thank you so much for your enthusiasm in this program. We would also like to thank the sponsor and the team for supporting this event, especially for our team in Indonesia who worked hard to run this 16th CPD ASIA. I hope that through this CPD ASIA platform, we can continuously share our knowledge and experience to transform the radiological services in each country. Once again, thank you for joining us, everyone. I hope you enjoyed the program. Thank you. I will hand it over to PG again. Thank you.
Thank you very much, President of PARI, Dr. Gyek Sugianto. This online CPD Asia is highly supported and graced by member societies, presidents and officers, and also representatives. Allow me to recognize them. Let us greet and welcome the President of Macau Radiological Technologists Association, MRTA, President Fernando Koch.
Hi, good evening. Welcome India and Mongolia, the first time to join us. Thank you.
We also have the President of Vietnam Association of Radiological Technologists, VART President Thai Van Loc. And we shall call him again later. Now, meantime, we have also President of Hong Kong Radiographers Association, HKRA, President Wan Shu Buan Nelson.
Hello, everyone.
Yes, we also have President of Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan Tu.
Hello, everyone. Good evening. Thank you.
We also have the Singapore Society of Radiographers, SSR, President Denise Chu. The President of Association of Cambodian Radiological Technologists, President Sophie Lee. We also have President of Philippine Association of Radiologic Technologists, Rolando Bañares. And also joining us is the Secretary General of Myanmar Society of Medical Radiation Technologists.
Hello, good evening. Nice to meet you all. Congratulations to your successful celebration this CPD.
Thank you so much, Secretary General Yin Yin Fan. Now, this is an important CPD Asia, for we have two new presidents and societies who will be joining the Asia CPD. We would like to call them, and here are some short messages from A. Salva Kumar, the President of the Indian Society of Radiographers and Technologists, ISRT.
Good evening all. Wish you all the best for today's program. Greetings from India, ISRT. Thank you.
And yes, we will also have new president and society joining the Asia CPD. We have the president of the Mongolian Society of Radiological Technologists, MSRT, President Tumi Berkdanch. So also joining us is our invited panelists from other countries. So this time we have Madam Chan Laikwan from Malaysia.
Hello everybody. See all of you again. Nice to meet everybody. Good evening.
Yes, so thank you very much, dear presidents, officers, and our invited panelists. Later, they will be joining us again during the Q&A session. So may I humbly request all the presidents and officers and representatives, our panelists and speakers to please open the cameras for a short photo session.
Okay, please wait, Pichi. I will take the whole picture. So, yeah, President, please look to the camera and I will take the shot now. Okay, first page. Yeah, I will setting the camera. Okay, 1, 2, 3. Okay, now the second page. 1, 2, 3. Third, fourth, fifth, sixth. Okay, done. There's a 22 page, I think, too long. Okay, Pichi, done for the photo session.
Yeah, so can I call again the president of Vietnam Association of Radiological Technologists, President Thai Van Loc, for your greetings?
I only say hello, everybody. I would just say welcome in India and Mongolia. Zone 2 in Asia CPD. Welcome, everybody. Thank you so much.
Thank you very much, VART President Thai Van Loc. So now, as we are all waiting to begin the program, allow me to briefly introduce our program moderator. Our program moderator is the lecturer at the Academy of Radiodiagnostic and Radiotherapy Engineering of Bali, Indonesia. Let us all welcome our program moderator for this 16th CPD Asia, Ms. Putu Irma Wulandari. Putu Irma.
Well, thank you, Pichi. Good evening, everyone, dear all presidents, the speakers, and obviously all of our participants. My name is Irma, and I'm your program moderator for today. First of all, thank you for joining us in the 16th CPD Asia event. And this month's topic for the CPD Asia is pediatric imaging. Ladies and gentlemen, pediatric imaging is such an important topic in radiology. This is because when performing procedures in pediatric patients, it requires dedicated imaging protocols. It also needs sedations or general anesthesia for longer examinations, such as MRI. It also needs specific training for the personnel through knowledge and expertise. And most importantly, it requires considerations for radiation exposure. So considering the importance of this topic, today we have invited 3 distinguished speakers to share their knowledge and experience in this field. So please allow me to introduce you to our first speaker. For the first speaker, we have Dr. Yarmaniani Miliati Muchtar, or usually called Dr. Yani. So Dr. Yani is a pediatric radiologist consultant at National Center for Women and Children's Health at Rumah Sakit Anak dan Bunda Harapan Kita, Jakarta. So Dr. Yani, are you with us?
Hello, good evening, everyone.
Thank
nice
you,
to
Dr.
meet you all.
Yes, thank you for accepting our invitations. So, ladies and gentlemen, today Dr. Yani will talk about the fetal MRI, especially the imaging protocol and case sharing. So, Dr. Yani, are you ready for your presentation?
Sure.
Yes, thank you. So, ladies and gentlemen, please enjoy the presentations by Dr. Yani.
Hello, everyone. Good evening to you all. My name is Yarmaniani. I work at RSAB Harapan Kita, National Women and Children's Health in Jakarta. First of all, I would like to thank to the organizing committee from Indonesian Association of Radiographers for inviting me to participate in the 16th Asia Continuous Professional Development. Please let me share my screen. In this occasion, I would like to present the fetal MRI, the imaging protocol, and case sharing. As introduction, we all already knew that the prenatal ultrasound is still the gold standard examination in pregnancy screening. But as other radiology modalities, the ultrasound has its own limitation, such as if the patient is large or there is scar in the abdomen of the mother. And for windowing, if there is no amniotic fluid, so the ultrasound has its limitation to assess the abnormalities. And also the fetal position. The fetal position make the ultrasound operator difficulties to visualize the abnormalities in question. Ultrasound findings sometimes subtle and need further investigation regarding the anomalies. Also, if we face the complex conditions such as in the conjoined twin or twin-to-twin transfusion syndrome case. We already knew that the fetal and magnetic resonance imaging or fetal MRI is not using the ionizing radiation. It has excellent tissue contrast and provides large field of view and not limited by maternal body habitus. It also has the multiplanar ability to image the fetus. The time to do the fetal MR scan is at 18 weeks gestation age of or more, because we hope that after that age, the organ is already visuals or developed well. The limitation of the fetal MR is the technical challenges such as the motion artifact, the limited fast sequences, and how to optimize this SNR, and the lack of technical expertise if we seldom do the examination. And how about the safety issues? There is no evidence harmful effects to the fetus, but no long-term safety has not firmly established. Because of that, we need to make sure the safety parameters in doing the fetal MR scan, that we always scan the fetus in normal mode, minimize the time scanning, and intercalate high SAR sequences with lower SAR sequences. This is the indication that I took from the Pediatric Radiology's website. The first indication is when the subtle abnormality seen on ultrasound, and we need more information in order to make a decision about the management of the patient, such as the therapy or the delivery of mode, and to advise a family about the prognosis or counseling. The second one is if there is abnormality identified on ultrasound and the treating physician desires MR specific information to make a decision about the care, such as fetal lung volumes in the case of congenital diaphragmatic hernia. The third one is if there is a significantly risk for abnormality, but the ultrasound cannot discover it, such as brain injury, early brain injury in the twin-to-twin transfusion syndrome. This is the table for indication that I took from ACR SPR practice parameter. You can appreciate that the indication is a rich array, large array, and then you can see that all systems can be included to the examination. For a good examination, we need a good preparation. First, do consent the patient, and then do screen your patient before entering the MR suite, just like the other patient. And we make the mother fasting about 4 hours before scan. This is need to be done to reduce the bowel movement, but in current research, they said that it's not significant. And we scan the patient early in the morning to reduce the fetal movement. And don't forget to have the mother empty her bladder before going to the room. And also positioning. We need to position the patient according to her preference and comfort. The feet go first, and then the lateral decubitus is more preferred than the supine position. If it's possible, put her in the left side to avoid the compression against the abdominal aortic structure. And give the patient pillows and blanket if necessary. And to reduce the patient anxiety, the patient can be accompanied by a family member or given oral sedation or oxygen supplementation if there is indication in that. Next is the positioning of the coil. We use torso phase array surface body coil, 1 or 2, and then wrap it over the patient. So the patient will be in the center of the coil, like sandwich. And you select the cell elements closest to the uterus to increase your SNR. And if your patient is too large, use the coil intrinsic to the magnet. And then next, we should have a planning before the examination. So we have to know the clinical information about the patient, so you can get the information about what is the area of concern, where is the abnormalities that we should look for to visualize it better. And then we have to understand the purpose of the study and do communication with your radiologist. Prepare for the technical and safety issues regarding the condition of the patient. For example, if you are dealing with the polyhydramnios, it will be different if you are facing the case with no amniotic fluid. Please consider to do the effective time scan to reduce the SAR. The Society of Pediatric Radiology website provides samples for specific system abnormalities and vendor-related imaging protocols. You can use that to make your own protocoling so that you can get effective time scanning when you are doing your fetal MR service. This is the dedicated protocol that I took from the website. This is from Cincinnati Children's Medical Center from Dr. Beth Kleinfeld. You can see that this is the protocol for each system or system abnormalities, such as in congenital diaphragmatic hernia, the bladder outlet or renal obstruction protocol, the neuro case in Chiari or myelomeningocele, and also basic fetal hydrops protocol. So what are we going to do when we start the scan? First, please document correct patient position. Which one is the right side and the left side of the mother, because it is going to be like the baseline for your fetus position. And then initial localizer with single shot T2 weighted. First, do your maternal scan with large field of view in coronal and sagittal plane that covered the uterus, the placenta, and mom's pathology. The next one is you do the fetal scan. Scout acquisition to visualize the fetus. Put your ROI in the center of the coil. So if the area of concern is in the body, please make sure that your coil in good position in that and put your ROI in the center of it. Maybe you have to reposition your coil in order to get the best signal to the area of interest. And when scanning the fetus, don't forget to look for anatomical landmarks such as fetus position. You know that the baby is not lying still, sometimes moving, sometimes twisting. So the brain and the body, you have to know your anatomical landmarks. In the brain, there is an interhemispheric fissure, and the body, there is a spine. You can make as an anatomical landmarks. When scanning the baby, first, you need to scan the area of interest where the abnormality is concerned using anatomic sequences in 3-plane, and then use your last set of images to set up the next sequences. And then you scan the other system. For brain, you need to scan 3 to 4 millimeter slice all 3 planes. And for body, you use 4 to 5 millimeter slice of all 3 planes. It depends of which age is the gestation you have. And since we are dealing with moving fetus, the speed is crucial. So we need to do our fast sequences first. We can use the workhorse of the fetal MRI is the single shot T2 weighted and the balanced steady state free precision images. And then you do the gradient echo T1. Next is diffusion. You can add on a cine steady state free precision and an echoplanar imaging or API depending on your clinical scenario. This is the table that consists the vendor sequences used in fetal MRI. You can refer this for your machine. To give you a big picture what kind of organ signals in fetal MR at T1 and T2 weighted images, this is the table that I took from the same reference. You must know that there is organ that high signal in T1 that is important to us to understand the pathology of the fetus, such as meconium. What happens if we get a poor images? First, make sure there is no metal around the mother, such as in the underwear. And then please make sure that the coil is in good position and the coil connectors are in place. Involve your radiologist. And if you deal with a large maternal body habitus, make an adjustment with larger slice thickness, increasing your field of view, and increase your number of averages. And if you are dealing with a small fetal size due to the smaller gestation age or because of there is intrauterine growth retardation, please do thinner slice, make smaller FOV, and utilize half of the coil. Again, the customized scan is the key. Please do adjust it to your clinical scenario with your patient. overcome the artifacts is your expertise, guys. So it will be different in 1.5 and 3 system. And in the 3 Tesla system, we are dealing with also the electric artifact. Complication can complication can come from the mother and can also come from the baby. From the mother, please pay attention to the cervix. If you see the cervix is thinning or opening, or there is a fluid in the proximal vagina, you maybe have the potential labor or water broke on the table. So be prepared of it. And then if the mother is like compressing his abdominal aorta too long, the mother can collapse inside the MR suit. So please also be prepared for that possibility. And the second one is be aware of the sign of fetal demise. If you see that the baby is not moving during the examination or decreased fetal movement, or if you see a bright blood in the black blood sequences, or you see the black blood in the bright blood sequence, and also if you see the blood in the cord of the fetus. And also if you see there is a poor definition of kidney and brain with soft tissue swelling. After the examination, don't forget to make sure the patient and fetus condition before discharging them. Review the image with your radiologist, and for processing the volume measurement, you need to give us non-motion single-shot T2 weighted series in coronal plane. This is the maternal scan. You see, we start with the large FOV that covered almost all the maternal organ, and we can also appreciate the uterus and placenta, also the cervix, and you can get the presentation of the baby, of course. And for the presentation of the body, the fetal position, sometimes you get it very good, flex in sagittal, head up, but sometimes you get it twisted like this, very flex because of the anomalies the baby have. So be prepared that maybe you have the difficulties when trying to get the good images that should be symmetrical anatomically. We move on to the artifacts. This is the artifact that can be seen in the system. In the fetal MR, you can see on your right hand side is the electric artifact, the black band that you see in the center of the uterus in sagittal plane in this example, and on your right hand side is the banding artifact that luckily is not to bother the evaluation of the baby, but you can see that if the band is on the center, present on the center of your area of interest, it would be a problem. It's not going to be a nice image to evaluate. And on your right hand side slide, there is a fetal movement artifact. Next, for brain scan, we do the 3-plane coronal, axial, and sagittal in two T2 sequences, and also for T1 sequence, and also for the body. I present you only here in the T1 weighted images in 3 planes, just to want to present to you how meconium that is hyper intense in the bowel will be visualized in T1 weighted images. We move on to the neuro case. This is a hydrocephalus sent by our OBG, and then it end up having another abnormality, such as there is a neural tube defect in the lumbosacral area with feathered cord and syrinx. Another one is the dysgenesis of corpus callosum with nodular heterotopia multiple in the posterior aspect of the ventricle, and we cannot see the vermis cerebelli. And then this is the body case. Just again want to emphasize that the fetal can be in every position. In these examples, you can see that it is like flex to his back, and then there is herniation of the abdominal organ. The liver and the bowel is protruded outside the abdominal cavity. This is the case of omphalocele. Another one is the patient that's sent to us concerning of meningocele, but finally we see the cystic mass in the pelvic area that consistent with cystic sacrococcygeal. Move on to the next case. This is the case where there is no fluid surrounding the babies. And then you can also see that the baby is very small, and yet you can still get the moving artifact from the fetus. The next case is the fetal hydrops. You can also appreciate the mom's pathology, that is right hydronephrosis, and the baby has the generalized soft tissue edema, and then there is a lung mass in the right side of the lung, and then also the ascites. In the sagittal plane from the same fetus, you can also appreciate the abnormal signal intensity in the ventricular system. And you can also appreciate in your right hand side is the fetal moving artifact. This is the scan from the fetus brain. You can also see the hypointensity in the intraventricular area that consistent with the hemorrhage. The last one is the case of conjoined twin. With this large of view scan, you can see that this is a craniovagus twin that fuse in the midline in the vertex area. The baby has their own brain but shared the dural venous and also the meninges. For conclusion, fetal MRI is a valuable complement to prenatal ultrasound, and it has higher contrast resolution, having large field of view, and the ability to image fetus in multiplanar. It is more precise than ultrasound for anatomic evaluation, especially in complex cases. Its limitation is due to technical challenges that can result in poor scan. So a poor scan leads to poor images that make us a poor diagnostic accuracy. So to avoid that, please do good preparation, good planning, and troubleshooting problems during the examination, and please involve everyone in your scanning. When you are dealing with artifacts that is degraded your image quality, please anticipate it and with several technical adjustments. And to radiologists in charge, they have to carefully interpret the study. And the last but not least, try to limit the scan time. Please customize the protocol. And finally, learning curve is the key to anyone that is involved in the study. With that, I end up my presentation. Thank you for your attention.
Well, thank you, Dr. Yani, for your amazing presentations. That was such an interesting presentations. So, ladies and gentlemen, Dr. Yani has emphasized some key points that must be considered during the fetal MRI examinations, starting from the exam preparations, the planning, post-exam procedure, image evaluations, and some interesting pictures of interesting cases. Thank you for sharing with us, Dr. Yani. So, ladies and gentlemen, if you have any questions regarding the topics delivered by our speakers, please post your questions through the chat box. Okay, Dr. Yani, can you hold for a moment? We will continue to the next speaker before we discuss the questions from the audience, if that's okay for you.
Sure.
Well, thank you. Well, ladies and gentlemen, the second speaker is Mr. Irfan Rivai. Mr. Irfan is a senior radiographer at National Cardiac and Vascular Center of Harapan Kita Hospital, Jakarta. Good evening, Mr. Irfan. Can you hear me?
Good evening, Irma. Good evening, everybody. Nice to meet you at 16th CPD online radiographers.
Thank you for accepting our request to be a speaker tonight, Mr. Irfan. And ladies and gentlemen, tonight, Mr. Irfan will be talking about the technical aspect of cardiac CT on congenital heart diseases. So, Mr. Irfan, whenever you're ready, the time is yours. Ladies and gentlemen, this is the presentations from Mr. Irfan.
Okay, good evening, dear all honorable panelists, and dear all my colleagues radiographer all over Asia. Nice to meet you at the 16th CPD Asia online for radiographer. It is an honor for me to be chosen as one of the speaker, and according to the topic tonight, I will share my experience in CTA, GHD, congenital heart disease. And furthermore, let me share the screen. Okay. This is a cardiac CT for congenital heart disease. Before we go to the topic, let me introduce. The cardiac anomaly in pediatric range from inconsequential to life-threatening and consists of congenital heart disease and acquired lesion. And it acquired vascular abnormalities such as infection, inflammation, connective tissue disorder, or iatrogenic. And congenital heart disease occur in about 6 to 8 of 1,000 live births. And the National Cardiovascular Center Harapan Kita Jakarta as a top referral for pediatric and CST Indonesia. In 2012, it recorded about almost 1,000 cases per year, and it increased years by years until now. And the CTA CSD examination about 500 to 600 per year. This is the modality of cardiac, and topic tonight is CTA. As per we knows, echocardiography is effective, non-invasive. It still remains the first line and the most commonly used method for diagnosis GHD. Diagnosis catheterization has long been the gold standard for evaluating cardiac anatomy and function, and currently is reserved for intervention and obtaining direct hemodynamic measurement. And a statement in 2011, a complete cardiac echocardiography imaging, all alternative non-invasive imaging modes, such as MRI or CT, are indicated before invasive cardiac catheterization or facilitate planning of data collection and performance of an intervention. And go to the topic, cardiac CT angiography. The cardiac CT is a non-invasive and credible examination with fast scanning and clear visualization of cardiovascular deformities. Why we choose the cardiac CT? Because its strength, it has a strength. The number one, the strength of cardiac CT is the 2D and 3D images demonstrate extra and extra cardiac structures and coronary arteries anomalies, and requires laser intravascular contrast material. It has rapid imaging, requires less patient sedation. It has a less artifact. It's good for airways and lungs imaging, and it can be used for evaluation or individual with implanted pacemaker and metal surgical hardware or non-cooperative or claustrophobia patient. But the cardiac CT has a limitation too, such as radiation, and it cannot provide hemodynamic information, flow and volume, as echo and MRI has. And it has limitation to evaluate intracardiac anomalies. When we use CT as an adjunct of echocardiography, when echo or cardiac catheterization data is suboptimal and unable to provide sufficient quality, and where CT more effective, it has aortic root and aortic arch disease, anomaly of pulmonary vein drainage, anomaly of systemic vein, RVOT, conduit, PA branch, pulmonary hypertension due to pulmonary embolism, coronary anomaly, lung parenchyma, and mass. Okay, we go to the patient preparation. Now, number one and the most important thing in CTA, GSD or congenital heart disease is IV line, IV access. Okay, because we can do CTA without IV line. And then number two is sedation, especially for non-cooperative and babies or little toddler patient. Usually we give the chlorhydrate 50 milligram per kilogram body weight. But for a patient adult GSD, we don't give it. And we have to explain the procedure to the cooperative patient or adult patient or patient parent. And for the Fontan procedure evaluation, if it's possible to put the IV line access in the lower extremity due to the position of the conduit in the IVC. And for the conjoined twin patient, especially in thoracopagus type, the IV line at the both baby is needed. Contrast media. The contrast media, we use this non-ionic and low or isoosmolar. It's okay, and we give the dose contrast up to time body weights, and flow rate is 2 cc per second or depend on body weight. In the adult patient with GSD, we treat the patient as the adult patient, so we can give until 3 cc per second or 3.5 cc per second. And if we use the injector, we give the flushing with natrium chloride 0.9%. In my experience, if we have patient under 20 kilogram body weight, we suggest to do the injection by the hand injection, hand bolus, because we don't want to take a risk with the injector if the patient is too small. We can imagine the patient only 5 kilogram or 4 kilograms. How many contrasts we have to use? It's very, very risky, I think. So, in my experience, if a patient under 20 kilograms, we do the hand injection. But the patient over 20 kilograms, we can use the injector because I think it's safe for the patient, because we use the bigger IV cat number 22, and we can use the pressure almost 250 psi. Is it safe due to my experience? The scanning process, the scanning times depend on the size of the patient, of course. The bigger patient, the scanning time is much longer. And average scan time less than 3 seconds because the past examination is needed for the limitation of the radiations. Mostly performed without ECG gating, except in the several cases such as coronary anomaly, coronary fistula, or Kawasaki disease. This is ECG is used for the adult patient which understand the instruction. But if we have a patient with coronary disorder, but the patient is small or baby or toddler and not cooperative, in my experience, we do the examination without ECG because if we do with the ECG, it is impossible because the heart rate is too high and the patient does not understand instruction, and maybe the baby is asleep due to the sedation. And both automatic time bolus or bolus tracking or fixed delay time can be applied. Of course, we use the injector for this, and most ROE put in the main pulmonary artery because, as per we know, the congenital heart disease is the right heart disease commonly, and the fixed delay time range between 20 to 25 seconds after injection if we use the injector. Because in my experience, 20 and 25% is still pace for 2 ventricle. We can still show the right ventricle and still show the left ventricle. Our port chamber is enhanced. And how to minimize radiation? The first thing to minimize the radiation is to do it without ECG gating, because if we use with ECG, of course we use the low pitch and table movement is very slow. It can be increase the radiation, and we have to optimize CT setting based on anatomic of interest of decreased area. Okay, not much longer, not too long, from the apex to the inferior of the heart. We use the low MA 50 to 150 milliampere. We use the low kilovoltage, only 80 to 100 kilovoltage. And if we use the helical or non-ECG, we increase the pitch until 1 to 1.5 pitch factor. And if we do with the ECG, we use a 0.2 pitch. Or if dear colleagues have a machine scanner with the flash mode, where it can possible to scan the patient in the very fast, it can be used. It's a very good. And the problem will occur such an intravenous access. So sometimes we have the difficulty to make an IV access, and some patient must be referred to anesthesiologist or pediatrician to deep vein access. And non-cooperative children, moving motion during the scanning, this is it's common problem will occur in CTA GHD. And ECG gating is needed in several cases, such as coronary evaluation in adult patient. So it increases the dose of radiation. Clinical indication. As a good radiographer, after scanning patient, we require to be able to analyze the image. In CTA GHD, we have to able to define the heart position within the chest cavity, define the abdominal, atrial, and bronchial situs, define the atrial ventricle connection, define the ventricle atrial connection, characterize systemic venous drainage, and so on. This is, I think, it's very important for the radiographer, increase the knowledge about the anatomy and physiology of the cardiac, normal and abnormal. This is a sample image for sequential analysis. Okay, this is good image. Yeah. The objective of the examination, we have to evaluate the location of the defect, measure the diameter of the defect, evaluate the pulmonary vein drainage, and document the information that needed for the interventional closure. We have to collaborate with the clinician when we process the image at the workstation. I think we have to sit together by the clinician to ask the clinician what they need to know about the patient. After we read the clinic, the referral letter from the owner. This is a sample from ASD, PhD, PDA. As a good radiographer, we have to know about the abnormalities or disorder. This is aorta and aortic arch abnormalities. Some objectives is establish the location, size, and patency of the aorta and its major branches, assess arch number and caliber, describe branching pattern of head and neck vessel, access to the possibility of vascular ring, describe present and cause of aberrant supralapian artery. These objectives is often occur in the CT-CSD. So we have to develop our knowledge in anatomy and physiology and pathology of CT-CSD. This is image for severe up. This is good image. It's a double arc. This is a aberrant right subclavian artery. This is type of many abnormalities at the vessel. The CTA, CS2 can show the abnormalities at the aorta and its branches, such as renalis, stenosis at the renalis artery, stenosis at the iliaca, and etc. The objective, we have to access the RPOT or right ventricle outflow tract, or fixed narrowing of subpulmonary infundibulum, access pulmonary valve morphology, the access pulmonary arteries, confluence, caliber, and branches, identify an additional PSDs, identify any PDA, look for aortic root dilatation, look for collateral or Muchtar. And I want to share to the dear college radiographer, I think we have to increase our development, our knowledge about the terminology, many terminology at the CSD, like VSD, PDA, Muchtar. We have to know what is RPOT, ILPOT. We have to know that. This is a tetralogy of Fallot. It's the most cases frequent in CSD. There are 4 disorders like PSD, operating aorta, pulmonary stenosis, and right ventricle hypertrophy. This is the most cases in CSD. This is very simple. The data from the scanning, it can use by the doctor of surgery, thoracic surgery, to based on his operating. See that? This is a aneurysm in TOF with EA. Aneurysm at the pulmonary artery. Muchtar, major autopulmonary collaterals. This is collateral to the pulmonary. This is pulmonary atresia and non-component PA, RPA from the aorta, the aorta, MPA from PDA with aberrant LCA. The objective is to evaluate the drainage of systemic and pulmonary veins, identify the presence of obstruction, identify of cardiovascularization, and the location of the defect. This is a bilateral superior vena cava. Yeah, many type of vena cava. Sometimes only one, sometimes the bilateral. This is a TRPPD, a total anomaly of pulmonary vein drainage to ventricle vein. This is one type of TRPPD. This is two innominate vein TRPPD. This is to left SVC TRPPD. And now we go to the coronary arteries abnormalities. And the objective is we have to delineate coronary artery anatomy, of course, and look for the aortic root dilatation and visualize other possibly affected vessel. This is a sample for single coronary arterial from the left sinus. Coronary fistula. The objective, we have to delineate coronary course and aneurysm. We have to document the location and size of the fistula. We have to visualize other possibly affected vessel. This is the sample of the coronary fistula, RCA to pulmonary artery. This is we do it without ECG because the patient is too small. Okay, but it can still show the coronary in good image. This is LCA and our ascending aorta aneurysm post-Ripper coronary fistula. We do it without ECG, but still got the coronary artery in the good image, in good quality. Kawasaki disease. Kawasaki disease is we have to delineate coronary course and aneurysm. We document the aneurysm number, location, and size of the aneurysm. Identify thrombus formation within aneurysm. Visualize other possibly affected vessel. When we do Kawasaki disease in adult patient, yeah, as I thought before in the previous slide, Kawasaki disease is the abnormalities at the coronary artery. So we do it with ECG if it's possible. But if the patient is too small or baby, and based on my experience, we do it without ECG. This is the Kawasaki sample. We do it with ECG for the baby 2 years old. Okay, we can delineate the number, the size of the aneurysm. This is the VRT image. We can evaluation post-op in CTA, S.ST, such as central shunt from aorta to RPA and LPA. This is a right BT or block toxic shunt. We can evaluate. This is we can see the patency of the BT shunt. We can see the occlusion at the RBT shunt. See that the radiolucent. This is the black one, and this is a partially thrombosis at LBT shunt. This is in axial view. See that? Okay. This one, the lucent. And we can evaluate the sacral aneurysm in post-total correction. This is the sacral aneurysm post-operation total correction of TOF. This is aneurysm. This is PRT. This is MIP. And we can evaluate the residual LPA stenosis in post-total correction TOF. This is pulmonary hypertension at causal pulmonary embolism. This is good image for pulmonary embolism. This one. Okay. Okay. And this is agenous LPA and left lung. See that? No lung at the left side. And for Pontan procedure, as I told in the previous slide, we make the IV line at the lower extremity. But if it's not possible, okay, we make it at the upper extremity. But we scan in the late pass or the delay pass because due to the conduit is in the IVC. So we can evaluate the patency of the conduit. And for conjoined twins, we can evaluate the blood flow across from baby number 1 to number 2. We inject from the IV access from the baby number 1, and if it's crossed to the baby number 2, it means there is some junction to about the baby. Okay. The conclusion. Diagnostic imaging is fundamental in the evaluation of pediatric cardiac anatomy. Echocardiography remains the first line imaging modality. Cardiac CT provides non-invasive visualization of morphologic changes in pediatric cardiac anomaly. The use of cardiac CT as a junction to echocardiography to evaluate pediatric cardiac anomaly should be considered. And the last from me, as a radiographer, I think to challenge the technology, we have to learn about the congenital disease, cardiac. We have to share, we have to ask the doctor, the clinician. It can be a cardiologist or radiologist to share the knowledge. Okay. So we can do better examination if we know the anatomy, physiology, and the pathologies. Okay, this is from me. I hope it's useful for the dear oncologists. Thank you very much.
Well, thank you, Mr. Irfan, for your great presentation. So, ladies and gentlemen, Mr. Irfan has shared some practical tips in performing CT scans in some interesting cases. Thank you for your sharing, Mr. Irfan.
You're welcome.
Well, ladies and gentlemen, next, last but not least, our third speaker is Mr. Krista Widianto. Mr. Krista is a radiographer from Premier Hospital Surabaya. And today, Mr. Krista will be talking about brain spine for Neonatus-Padiatric MR imaging. Mr. Krista, can you hear me?
Yes, selamat malam, good evening.
Good evening, Mr. Krista. Thank you for joining us today. Well, are you ready for your presentation?
Yes, but I'm still in hospital.
Okay. Okay, thank you. Well, ladies and gentlemen, please enjoy the presentations from Mr. Krista Widianto.
Okay, selamat malam, good evening for all the participants and colleagues inside Indonesia and outside Indonesia, and also all of the panelists. I'm Krista Widianto. I'm from Premier Hospital Surabaya. Surabaya is the second biggest city in Indonesia. First of all, I would like to say thank you for all Indonesia Committee for having this opportunity. Thank you for having me in this occasion. Okay, in our center, we use Tritesa Philips Ingenia. So all of the images I taken from the machine. Allocation time for me is 25 minutes. Hopefully all of the pages and material could be delivered in time. This time, let us discuss about the neonatus and pediatric MR imaging. And we focus on the most frequent cases on brain and spine, the position, the coil, and also what doctor need to know about to make the diagnostic, and also the data that the radiographer have to provide. Okay, I would share screen. Yeah. Okay. Brain spine for Neonatus-Padiatric MR imaging, most frequent cases including anesthesia preparation. Okay. As we know that MR imaging for neonatal and pediatric, and the first one, we have special registration and anamnesis because the patient is children, because the patient is baby and infant. So the information about the latest condition, about the healthy issues, including the weight, tall, any allergy or other issues, is we get from the parent. So we have to communicate with the parent about the latest condition of the patient. And then the complaint of the patient, we cannot asking the patient about the complaint of their self. So we also need to know the information from the parents. And then mostly undergoing with sedative or anesthesia procedure, because as we know that MRI is need scan time, longer scan time, and the baby we cannot control which the baby not move during the examination. So the sedative or anesthesia procedure is a must or common, mostly common undergoing. And then we need to organizing the exam day, because to do MRI for the baby, there are many staff to get involved. We need to arrange precise schedule for the anesthesiologist, and then the nurse, the certified nurse, and radiologist as well. So we have to organizing the exam days. And then the number 4 is, of course, informed consent for anesthesia and for MRI procedure. Okay. The sedative procedure preparation, this is doing a day, at least a day before MRI procedure. So patient should be having consultation with anesthesiologist, and then the anesthesiologist team will be planning with the radiologist department or MRI department to organize how long the exam will last, and then kind of contrast, how many milliliter contrast that needed, and then method of injecting of contrast if needed contrast, if the patient needed contrast. So we have to make sure kind of contrast, and then how many milliliter contrast that needed, and then the method of injecting. And then the kind of position that during the examination for the patient. Within is can be supine or prone or lay on left side. The sedative procedure operation, we need on-site supported staff. So staff that must be on-site on the room of the MRI during the examination. There will be anesthesiologist, the doctor from anesthesia, and then certified anesthesia nurse, the nurse that a specialist in anesthesia, radiographer, and also radiologist. Sedative procedure preparation. On-site supporting devices that we have to providing, all devices which on the scanner must be MR safe. So all of the devices, including the number 1 is physical vital site monitor, and then positive pressure oxygen or PPU or Sp.O2 delivery system, and then ECG lead, blood pressure kit, and then appropriate flow meter within it wall O2 flow circulation, and then liquid infused solution stand. It stands for infused, and then suction device could be wall suction or portable, with an assortment of catheters suitable for the small children. The size of the catheter is depend on the size of the children of the patient. And then backup portable oxygen cylinder should be available outside the scanner. And most important is emergency resuscitation. It usually provided by anesthesia team. All of the devices that on the scanner must be MR safe. Okay, this is the position and coil management. Okay, we handle the baby, the infant. So the position should be supine or lay on the right or the left side. It depends on the condition of the patient. Okay, this is the example that the patient use the ECG in the heart, and then the PPO saturated, and then if the doctor need blood pressure kit, we should be provided blood pressure kit also. Yeah. This is the monitor that should be providing inside of the MRI machine. Okay, so this is the photo that taken currently on the situation when the baby or infant doing MRI. So the stand guy is the anesthesiologist, and the other one who sit down is the nurse. And then they are with the devices like monitor, ECG, PPU, and so on. Okay, so for the baby, the coil that we can choose is 3. The first one is brain with 32 channel, and then the second one is brain with 16 channel, and then the anterior one. Okay, now we discuss about the coil brain for 32 channel first. The position will be like that. Will be in the slideshow. So the baby we place a supine because the baby don't have any bulging mass in the back. So the earplug must be inserted well. This is not ear plug. I mean, this is the headphone, and then we place the baby in the saddle. So the baby is comfortable for the baby, for the patient, and also comfortable for the anesthesiology to evaluation during the examination. This is before we close the coil, and then after we close the coil with 32 channel. What if the baby have a bulging mass in the back like this? So we cannot place the baby upside down in the prone condition, in the prone position, but we need to place the baby lay on the side, which is in the right side or on the left side. So this is the doll I bring. So this one, if the baby have a lesion in the back, so we cannot automatically we cannot place the baby on the supine condition. So we let the baby in the position in the lay on the right side or lay on the left side. Okay, this is the example like this. If the baby has a bulging mass. Okay, this is the coil craniocervical for 60 channel, the second choice, like this. So if the baby have a mass, will be like this. Okay, this one. Now, And then the third is by using anterior coil. If we use anterior coil like this, now, so we need to make sure that do not let the coil overbearing or pressing or contact with the body of the patient, because the coil is too heavy for the baby. So if the baby, if the coil is pressing the body of the baby, it will make the blockage of the airway of the baby, so the baby can hard to breathe, and then the doctor, the anesthesiologist, will be complaining that they can evaluate the baby well. Okay, so like this, if the baby have the bulging mass in the back, so the position will be like this. Okay, so we have to make sure that there is a space between the baby, between the baby and the surface of the coil. Do not let the coil pressing the baby or the patient. Okay, now we discuss about the most frequent cases in brain. Okay, the most cases in brain is, the first is about the congenital anomaly. Congenital brain malformation are a group of brain defect or disorder that develop in the womb and are present at the birth. So when the baby birth, they also bring the abnormality with their brain. It could be divided into three. The first is malformative lesion, and then the second one is destructive lesion, and the third one is migration lesion. So this is only nice to know for us, for radiographer, because this is we believe that this is the type is the doctor will be classified where is the type of the abnormality of the baby. So this is nice to know for us. Within the baby have a malformative lesion, destructive lesion, migration lesion, or another else. Okay, congenital anomalies or malformation. The protocol is standard brain protocol. We use T1, T2 flare, and then T1F for evaluation the angiography, the blood flow, and then the diffusion, and then SWI, SWIP in any projection, transversal, sagittal, and coronal. And then additional coronal T2 for hippocampus, and then ISL, and then spectroscopy for both side of hippocampal. This is only for clinical convulsion due to suspicious of epileptic case or hippocampal sclerotic. Mostly no contrast administration needed for the cases congenital anomaly or malformation. Okay, this is the example. The first is schizencephaly. Schizencephaly is the cleft or gaps can be filled with fluid and gray matter. So we focus that if the baby have the schizencephaly, so the hemisphere is not really completely formed. They will be replaced with the fluid or the gray matter. So the appearance will be like this. So they don't have any complete hemisphere. One of the hemisphere will be changed, will be replaced with the fluid like this. This is from the axial and this transversal, and this from the sagittal. And then the second one, the most common one, is microcephaly. Microcephaly is commonly, okay, microcephaly is brain hemisphere or parenchyma are smaller than common with some age. So if the patient have the microcephaly, so the size of their brain parenchyma is smaller than the other infant with the same sex, with the same X. Like this. This is the example. So there are the arrow one, the green arrow one is the space that the parenchyma is replaced by the other. It could be the space of paying, and then it could be the other fluid. Okay, this is convulsion at causa epileptic. So if the patient come with the epileptic, there are convulsion. So we have to focus on the hippocampus. The hippocampus is the yellow area. In the yellow area, this one can be the right and the left side. Okay, this one is the hippocampus. So if we want to make the coronal hippocampus, so we have to look out the sagittal first. So if the sagittal, if we already recognize where is the hippocampus, so we make the parallel line to hippocampus coronal projection. So the this line will be result with this image. So this coronal we make with this parallel line to hippocampus coronal. So like this. So to make the coronal like this, we have to make the slices like this. Okay, this is another example to make hippocampus like this. So we have to make the parallel line to coronal hippocampus like this. Okay, so we all have to make the spectroscopy, single spectroscopy for both of hippocampus, the right one and then the left one. And then most potential case in the brain, the other is infection. Okay. Okay, and the protocol for brain infection is standard brain protocol. We have to doing T1, T2, flare, and then MRI, and then DWI, division, and then SWI, and any projection, followed by post-gadolinium administration or post-contrast study. If your center have a 3D, so please doing 3D. 3D is preferred or better to evaluate the whole parenchyma of the brain. And the additional if the if there are the nodules in the parenchyma of the baby brain, so we have to make MR perfusion and MR spectroscopy. Contrast administration is needed. It's a must for the brain infection. Okay, this is the example from brain infection. We call it meningitis. So the arrow is the enhanced meninges that appears when we doing post-contrast. Okay, this is meningoencephalitis. So there are many green arrow. The green arrow is refers to product enhancing post-gadolinium with abnormal increasing leptomeningeal enhancement. So the green arrow is indicated that the patient, the parenchyma of the brain patient is have some infection. And then the most frequent in the brain is neoplasia. Neoplasia is a mass. So this one, the classification. This is nice to know for us because the doctor will be classifying the mass. Okay, from brain neoplasia, the protocol is standard brain protocol: T1, T2 flare, and then MRI, and then diffusion, and then SWIB, and then in any projection, followed by post-gadolinium administration study, and then additional MR perfusion and MR spectroscopy as well. Contrast administration is needed, is a must. This is the example of the brain mass, craniopharyngioma for the baby. Okay, like this. And this is the MRI. So in this appearance of the MRI, when the baby have a large, huge tumor like this, so the this can be occurring the non-visualized left MCA and right or left ACA, anterior circulation. Okay, now after we discussing about the brain, now we are discussing about the spine. Congenital anomaly for the spine is abnormalities, disorder of the spine that develop very early in life. Some of these conditions may cause abnormal alignment of the spine. Others may affect the nerve, causing problem in moving the arm or legs, through issues or pain. Many congenital spine disorder are related to spina bifida. Babies born with spina bifida aperta may have an open defect on their back where the skin over the spinal cord does not form correctly and the nerves are exposed. Spina bifida occulta is a condition that is not severe as an open defect. Children may have abnormalities in the bone, which may or may not cause symptoms. Okay, so the most frequent that according to our experience is myelocele and myelomeningocele. So we have to get the doctor. This is we focus at what the doctor want to know about the myelocele and myelomeningocele. What the data, what the image they need to know. They really need to know to classify, to differentiate between myelocele and myelomeningocele. The difference between myelocele is the spinal cord is exposed so that the nerve tissue lies exposed on the surface of the back without even a covering of skin of all the meninges, the membranous tissues surrounding the brain and spinal cords. And then the myelomeningocele, the condition as above, with a neural tube defect in which the bone of the spine do not completely form, followed by protrusion of the spinal cord system. The spinal cord system, and then we call it with plaque. Okay, so this is to make us easier to imagine what is the difference between the myelocele and the myelomeningocele. Okay. The first image is spina bifida occulta. So the spina bifida occulta is the bone is not completely formed. So there are a hole, but the hole doesn't make any any hazard situation. But the meningocele, the bone has a defect, but the meninges are protruded, and the myelomeningocele, not only the meninges that protruded, but followed by plaque. The central, the plaque is this one. The plaque is the spinal cord system. Okay, so for the myelomeningocele, not only the meninges that protrude, but also followed by the spinal cord. Okay, this is the case. Baby with just like this doll, the baby, if the baby have a lesion in the back, so we have to suspicious that the baby have the spina bifida, and then what the doctor need to know the most is the plaque. Yes, the doctor we have to providing the data, the image about the plaque, because the plaque will be the most thing that the doctor can be used for classified, which is the baby have meningocele or myelomeningocele. So this is the green arrow is the plaque. If the plaque is protruded with the meninges, so it it belongs to myelomeningocele. So like this, the plaque is also protrude with the meninges. So we can categorize it in the myelomeningocele like this. Okay. Spina bifida evaluation protocol We have standard spine protocol. We have to doing T1, T2 exploration in any projection, followed by MR myelography. And then if we need, if the lesion is too small, so we have to make the additional 3D Vista or any mention in other scanner, preferred for tiny yellow seal with small path tracking cases. No contrast administration needed for this case. Okay, this is what doctor need to know most, just like I told before. The plaque, a neurogenic plaque is an area of thickening of the epithelium in the membrane ectoderm layer that gives rise to the neuron of the structure of the sensory nervous system. So the plaque is the key. The doctor will be evaluate the plaque. Okay, this is arrows is the plaque, just like I told before. The arrows is the plaque. So the green arrows is this is the plaque. Okay, this is the case, and this is from the exploration. The plaque is outline of the defect area. Okay, this is from the axial, and the right images is the cord, and the left images is the outline of the plaque. So this is the doctor really need to know. Okay, this is from the coronal plaque outline, and then from the exploration in the right, and the T2 is in the left. Okay, if the lesion of the cell is too small, so we have to make 3D sequences or extra thin slice in the area of the lesion. So this is the image in the left and the right side is the sagittal. So small parts connecting canalis spinalis to subcutaneous lesion cause tether cord. This is just a very small part, and then this is the subcutaneous fluid collection. So if we facing with this clinics with this abnormality, so we have to make 3D. 3D is a must because without 3D we cannot tracing the small part. This is the doctor really needs to know the small part. Okay, this is the subcutaneous fluid, the fluid collection in the back. Okay, this is the sagittal one, the small parts, and then this is from the axial, the small part, and this is the spot marker. Okay. Okay, this is example of mass of the lesion, but do not have any connection with spinal canal or spinal cord patterns. So this is a really lesion that have no any connection with the spinal cord, no cerebrospinal fluid leakage, no spinal cord pattern. Okay, that's all. Thank you. This is the a little experience, our little experience in our Premier Hospital of Surabaya about the most frequent cases in brain and the spine. So this is the discussion. So if participant or panelists have any question or have any advice, of we are really glad to accept all the question and also the advice to make our images or our presentation better in the future. So thank you so much. Thank you for the attention. Terima kasih atas perhatiannya. Good evening. Selamat malam.
Well, thank you, Mr. Krista. Well done. That was such a great presentations and really comprehensive explanations about the cases you have encountered on practice. Thank you, Mr. Krista, for sharing with us. So ladies and gentlemen, don't forget to post your questions on the chat box if you have any questions to the topics delivered by our speakers. Okay, now let's move on to the next sessions, which is Q&A sessions. In this session, I would like to call again all of our speakers and the panelists to join us. And we already have some questions on the chat box, but before we discuss the questions from the audience, I would like to invite our panelists. Maybe from the panelists, do you have any comments or questions that would you like to ask to our speakers, please?
Okay, I have a several questions.
Yes, Mr. Locke, sure.
Yeah. Okay, the first, I'm all the way. I'm thinking Indonesia very well. Thank you so much in Indonesia. You are all the way. You are well all the way. And thank you and please speaker today. And thank you, Widianto, you organized for your society. Very good. Congratulations, Indonesia again. And the first question for Dr. Yarmaniani. I see in your lecture, very good lecture. You share experience for us. You see a second for fetal MRI. You say standard in T2 and radiant echo T1 and S.ST and diffusion. But my question for you, usually you use a diffusion or sometimes with special case, you must use a diffusion. The first question for Dr. Yarmaniani. The second for you, you can share for your experience with everybody, how your artifacts reduce, not only short time, you can share for everybody, how not only short time, we can use another one for not only short time for artifacts reduce. The second question for Dr. Yarmaniani. You okay? I want to have a question for Mr. Irfan. Thank you so much. You are with me. You are very experienced for cardiac CT for children. Very experienced. Which in congenital, and you very experienced. The first question for you, I see you say with the patient under 20 kilograms, you recommend for everybody hand bolus. My experience, I never use a hand bolus. When you use a hand bolus, you stay in CT room or you after you injected you go out. Yes, okay. Yes. I also agree with you. The second for you. I recommend for if you can use an ECG, you can use an ECG. If some special patient, you cannot use a non-ECG. You must non-ECG because ECG very important. We understand. The third question for you. I didn't see. I have an experience. I want to, sometimes you miss contrast. You miss contrast injection. You miss contrast in nitric chloride, and you miss together. And we have a many phase contrast and miss contrast and nitric chloride, and after nitric chloride only. I didn't see you have experience with miss contrast. Okay, 3 questions for Irfan. two questions for Dr. Yarmaniani. Okay.
Okay, thank you, Mr. Lok. So, Dr. Yani, we have a questions from Mr. Van Tai Lok from Vietnam. So, would you like to answer his questions first? Would you always use diffusion? Is that a question, Mr. Lok?
Yes.
Diffusion imaging, yes, Mr. Dr. Yani?
Diffusion, you sometimes you use the sometimes.
Yes. Okay, thank you, sir. We do use the diffusion sequences when we are assessing the possibility of having the brain injury. Usually in the case where the doctors is already send the patient to us with the suspicion of twin-to-twin transfusion syndrome. And also we do the diffusion to in the case of where you are suspecting or you have to assess the abnormalities of the kidney. We do always the diffusion in that two cases. To shorten the examination time, sometimes I skip those diffusion. It's not a routinely done, but for the brain case, usually we still do that all in diffusion scan through the brain. Hope that answers your.
Yes, okay. I'm thank you so much. The second question, you can say more. You can explain for everybody how not only I'm worried we fetal we worry artifacts reduce. Not only you recommend for everybody, not only short time. You can share. You can say more experience. Your experience.
Okay, sir. I know that most of our audience is maybe like an experienced radiology technologist, and I'm only a radiologist. But what can I say is, when you are scanning and we are scanning the fetal MR, first of all, we know that we are dealing with the structures that contain fluid. So it is important for you to adjust your field of view. Depending on your machine, in the 3 Tesla system, sometimes we need to put the electric pad on the mother to reduce the dielectric artifact. That's what I can share with my experience, because our machine is in 3 Tesla system. And then after that is you try to do the sequences that is to reduce the moving artifact for the mother or from the fetus. Sometimes we have to do the fast sequences first and then do the longer acquisition time, like in T1 the later on. So it will make the moving artifact less prominence in our images. And then also if we are maybe we have to do like not increasing your TR time and reducing it to make the acquisition time is lessened. And then the other one is like sometimes you do not have, maybe you depending on your machine, sometimes you have to do the interleaving gaps to make the acquisition time is fast enough, so you are going to get the images before the baby is moving. Hope that will help, sir.
Yeah.
Okay, Mr. Lok. Is that enough?
Yeah, enough. Thank
Okay.
you, Dr. Yarmaniani. Very well.
Yes, you can. Yeah, thank you.
Yes,
You can call me Yani.
Yes, thank you.
Dr. Yani, Mr. Lok.
Yeah, doctor.
Okay, thank you, Mr. Lok.
Yes.
For your questions, and thank you, Dr. Yani, for your response. For other panelists, do you have any questions or any points to discuss in this session?
Now, my question
Oh
for
yeah,
Irfan.
I'm sorry.
My question for
I'm
Irfan.
sorry, Mr. Lo. You still
Yes.
have a questions for Mr. Irfan.
Yes.
I'm
Yes.
sorry, Mr. Irfan.
Now, under 20 kilograms, you recommend for everybody hand bolus you inside in CT scan during export or you outside?
Okay, thank you, Mr. President. Yeah, due to my experience, baby patient or small patient under 20 kilograms, example 10 kilogram, we do it with hand injection, and we after injection, we immediately out. And in the control room, we have a friend or our partner. After we close the door and scan, so we inject the contrast after the start button is bling bling. I think bling bling. It's ready to start, and we inject immediately. Yeah, and then after finish injection, we go out and push the start button. Oh, if you have a gantry start button, is it a benefit? Is very better. Some machine had a gantry start button, and some not have. That's my answer, Mr. President.
Yes, but if you inside, maybe pay more salary for you. ready instant salary.
No.
You miss contrast. Yes, second question for you. You share for everybody. How many second total for one case? You usually 3 seconds or for 2 seconds for one case. The second question, and the one more question. I didn't see you say miss contrast in when you injection. You miss contrast to get.
Okay, for the one case, we usually only 2 or 3 second scan time.
Yeah.
Yeah, without ECG. This is a helical scan, because we increase the pitch factor, because we have to scan in the fast due to the radiation and avoid the moving artifact. We do it without ECG because some or many case of S.ST is not coronary purpose. It's only anatomical of cardiac, not coronary. You want only that look for the disorder in chamber, in the large arterial, such pulmonary or aorta, or want to show the shunt between the chamber, ESD, VSD, not coronary purpose, not coronary study. So I think we can do it without ECG. Okay, if we need coronary study or coronary purpose, such a coronary anomalies, such a Kawasaki disease in adult patients, so we better do it with ECG due to the cardiac pulsing artifact. Okay, and the third question, I don't understand.
Miss contrast ingestion during ingestion, we miss contrast.
You mix the contrast.
Yes.
Oh, mix the contrast. Yeah.
Yes.
Mix or miss?
Yeah.
Mix. Do you mean mix the contrast with the saline?
Yes, saline.
Oh yeah.
Okay. Okay. When we use the injector, of course we use the saline after the injection. It's routinely, I think, after the contrast in one phase, and next phase is with saline. The amount of saline is about the same with the contrast. If we use the 20 cc of contrast, we use the 20 cc of saline. But if we use the hand injection, we need no saline, because if we inject saline after the contrast, and we go to the control room and there, maybe we lost the contrast because due to the arterial pace is too short. Okay, thank you.
Okay, thank you. I don't have question for Krista because he very well. Thank you so much. Yes,
Okay.
to continue. Thank you.
Thank you, Mr. Locke, for your questions. Very good, very well. For other panelists, do you have any questions or do you have anything to discuss on this session?
Yeah, if I may be allowed to react and ask a question also, Ms.
Yes, sure. Is it Peachy?
Yes.
Oh, yeah, sure.
So firstly, I would like to give congratulations to our 3 great speakers and to the PARI. I hope that in the next CPD Asia, you'd still consider having this topic as another topic for your next hosting of the program, because this pediatric imaging, as we will all agree, highly demands so much from the rad techs, not only for the technical skills that we have, but also considering communication skills with patients. For diagnostic imaging of pediatric patients would require so much to do before, during, and after scanning. My question for Sir Irfan, and I think other speakers can also answer too. This is in terms of generalized motion artifact. For older children, like greater than 7 years of age, with normal development, are often as we know, are often capable of lying still and also following instructions such as those required for adequate quality images can be obtained. But however, for neonates or infants or younger children and patients with developmental delay, can you share specific strategies that your institution employs in order to minimize motion artifact? Also, I'd like to ask if you also consider giving reward to pediatric patients after imaging, even if the imaging is not so successful.
Okay, thank you. Okay, I will try to answer. Due to my experience in my center, and if you have a problem with patient with mental development or such a kind like that, especially we have to explain the parents about the procedures. Okay, and sometimes we ask the parents to accompany the patient in the gantry to make the patient is so cool, and maybe we can give some sedation, and we collaborate with the pediatrician or the anesthesiologist. If it's necessary, we have to give the general anesthesiologist, because the CT is the fast examination. Only need I think only 5 second scan. So sometimes we do it. We just do it after we talk to the patient. We ask the parents to talk to the patient, so they have to understand this is for the patient treatment. And after the examination or during the examination, we sometimes promise the patient about the gift or present after. Sometimes we promised about the ice cream or candy or give him to use the cellular phone to see the YouTube or something. That's, I think, our experience.
Okay, thank you, Mr. Irfan. Pichi, do you have any? You are still in mute.
Can I add,
Yeah,
Mbak Irma?
Yeah, sure, sure.
Yeah, sure.
Okay, thank you. In my experience, if you are dealing with children or a patient with special needed, sometimes you cannot avoid to give a sedation. So in my hospital, in my institution, we always do under sedation. That's what I concern, because sometimes they cannot very cooperative or can tolerate the examination. Thank you.
Okay, thank you, Dr. Yani.
Okay, can I have a additional statement?
Oh yeah, sure, sure.
Okay, maybe in my experience, we doing MRI with a longer time scan than CT. So sedated is the must. The first, we have to organizing with the anesthesiologist about how long the appropriate MRI will be done, and then the right position for the infant, for the baby. So during the examination, the baby or the infant or the patient in the right position. So whether of the anesthesiologist, and we can doing scan with as fast as we can. And it's the first thing that we have to do, just to make the patient in the right and the most comfortable position. It is just for the anesthesiologist and for us to make the faster scan. This is according to our experience. Okay. So we have to organizing well with the anesthesiologist team.
Okay, thank you for your information, Mr. Krista. Maybe from other panelists, maybe you can share the practice in your country, or anyone would like to add anything on this discussion? Or Pichi, do you have any comments on the answers from our speakers?
Yeah, from what I've heard from one of the speakers, it's as if that there are techniques that are also employed in some other diagnostic utilities. Like I've heard that for pediatric, really, you need to start doing with the more fast imaging protocols, for consideration that the patient may not be able to tolerate the length and the course of the procedure. So the technologists really need to prioritize doing the priority protocols, or the first few faster techniques. So yeah, I would like to applaud that the third speaker, Sir, I think he was the one I'm referring to, Sir Krista. Yeah.
Yes.
I appreciate your presentation because you have also included photos here, which are very important. But this is more a personal question. Did you really have, because I saw the doll with you, right? So did you really have created your own photos for your presentation? Because that is really very much impressive. And I'd like to know also that if you improvised, or those devices that are used for your positioning were made available by your institution.
Yes, yes. The doll is also with me.
Okay, very nice.
Still with me tonight, the doll is still with me tonight.
Did you improvise those some positioning aids that you used, or do you
Yeah.
think others can also make that available?
Yeah. So we have to focus the size of this, the size of the lesion of the baby. the bigger the lesion make the baby can position supine like this. And it is not allowed for anesthesiologist to position the baby like this. So the only position that can be allowed is lay on the right or of the left side, like this. Okay, so for our college's radiographer, if the patient, the position is lay on the right or of the left side, be careful with the projection. The coronal will be not the true coronal, because the coronal will be looks like the sagittal, and this is must be careful for a radiographer to determine which is the true coronal and the true sagittal if the patient is not anatomical supine position. This is the most important, I guess.
Really nice, Mr. Krista. Pichi, would you like to add some more comments?
Yeah, lastly, I would like to know, because I've heard from the first speaker, from the doctor speaker, that really most imaging for handling pediatric cases would require trained technologists. So I wonder if how Radtechs Indonesia were being trained, or how do they receive specialized training in pediatric imaging? Do they acquire this from on the job itself, or you were given training prior to entering your work in a specific diagnostic imaging department?
Thank you, Ms. Pichi. In our institution, we are like giving the on-site training. I know that maybe there is no specification, like just like maybe the other, like radiologists, there is a specific training for doing pediatric imaging. So I think it is more like general when my colleagues do their training, and then after that, when they are coming to the hospital, they like train themselves and teaching each other to do the special procedures or to handle a pediatric patient. That's is my question answer.
Hey, Pichi, you okay with that? Yeah. Okay, thank you. Well, thank you for the speakers and panelists for your comments and discussions. Before I end this session, are there any questions or any more comments from other panelists maybe? Or someone wants to share their experience in their own country maybe? No one?
I see many questions from in chat box. Very nice question. I think you choose some question and you read and for everybody.
Yes,
nice question. Many nice question.
Yes, I saw it too in the chat box. We already have some questions from participants, and most of the questions are already answered as well from by the speakers. And because of the time, it's already 9 o'clock in Indonesia. So the committee decided that we will post the questions and answer through our official website at pari.or.id. But if the speakers wants to discuss the most interesting questions from the audience, you're free to do it. From the speakers, maybe, do you have any questions that you want to discuss in this session? No? Okay, so for those whose questions haven't answered by the speakers, we will post the answer of your questions through our Instagram @info_PARI and our official website @pari.or.id, because we have a lot of questions from audience, and I think our speaker will also answer your questions after this meeting if you need more discussion. So we will post everything on our social media, if that's okay for everybody. Okay, if no more comments from the panelists, I think that's the end of this session. Okay, all right. So everybody, ladies and gentlemen, I think that's the end of this session, this Q&A sessions, and also ends our meeting for today. Once again, thank you so much for joining us in this event. And thank you again for all of our panelists, all of our speakers and audience. Really great discussions, really great presentations. And thank you for joining us. Next, for the closing, I will hand it over to Pichi again. Pichi, thank you.
Yes, thank you very much, our program moderator, Putu Irma Wulandari. And also, again, thank you so much to our distinguished speakers. We have 3 great speakers for this 16th CPD Asia. We have learned so much from your interesting and very important discussions. So finally, we have come to the end of our program, and as everybody knows, the next CPD Asia is coming by next month. We are all excited to know about the next exciting online CPD Asia schedule. And to address an invitation to tell us more about the exciting event, let us all welcome the Secretary General of the Myanmar Society of Medical Radiation Technology, Miss Madam Yin Tan.
Hello, good evening, everyone. Let me tell you all first, my congratulations this Asian CPD. Next, and heartily thank you all presidents and representatives for encouraging us to continue participations in Asian CPD events. We are trying to next 17 Asian CPD on July, Sunday morning, 9 a.m. to 12 p.m. On behalf of MSN Multi, I would like to invite to all presidents and all members of associations of countries to join us. Thank you.
Yes, thank you so much, Secretary General Madam Yin Tan of Myanmar Society of Medical Radiation Technology. We will surely be supporting you with the hosting of the next 17th CPD Asia, which is going to be surely a very big event. So everyone, please see updates and relative posts regarding the announcement of the 17th CPD Asia, which is going to be out soon. So please be updated always. So in closing, congratulations to the Indonesian Society of Radiographers, PARI, Perhimpunan Radiografer Indonesia, the officers, and the organizing committee of the 16th CPD Asia, most especially to President Dr. Giek Sugianto. We thank also the support of our sponsor, BT Healthcare Vietnam, and also we thank our great 3 speakers, Dr. Yarmaniani Muchtar, Mr. Irfan Rivai, and Krista Widianto. Most of all, we are sincerely grateful to all the member societies presidents, to our hardworking CPD Asia IT team, and to all registered more than 1,000 participants who have made this 16th online CPD Asia program a success. See you in the 17th online CPD Asia. Again, I am Pichi Luna, and I say thank you, everyone. Have a great night.
Thank you. Bye.
Thank you all.
Bye.
Bye-bye.
Thank you,
See you.
everyone.
Thank you
See
all.
you in 17 CPD.
Ya.
You.
Terima kasih.
Thank you.
Highlight Kwan. Thank you.
Yeah, I want to share something before you all close, because just now I was mute. To Pichi, you have written a letter and actually sent to the president. So yesterday we have our AGM, he said he has already emailed the response, but he didn't CC to me, so I don't know what's the outcome. But I think he still refused to join. It's not that he refused to participate, but he said Malaysia is still out, but he doesn't mind to just attend the CPD webinar. But Malaysia society is not going to take active part to sort of run a webinar.
Yeah, good.
I think that is the response, but thank you very much.
Thank you, Melissa. Thank you
for the invitation.
Lok, Mr. Lok,
Yes.
I think India ready for August, and the next after July, India is already ready to do the webinar.
Yes, we discussed in group messenger.
Okay.
I see your message. Yeah, we discussed together in messenger group. Yeah.
I thank you, everybody. I like today's webinar
Thank you.
also. Congratulations.
Thank you, Bunda.
Your speaker is very
Reverend Indonesia.
Yeah, thank you.
Thank you so much.
Malaysia.
Good night, Mr. Sukianto.
Yeah.
Very well.
Thank you. See you.
Thank you.
In July.
Good night, good night, everyone. Good night.
Terima
Bye,
kasih
bye-bye.
semuanya, Putu, Irma, Putu Adi.
Yeah, terima
Nelson,
kasih
thank you.
Bapak. Good night, everyone. Thank you.
Thank you. Pak Irma, Mas Adi, saya izin pamit ya.
Terima kasih Bapak. Terima
Ibu
kasih
Dr.
Dr. Yani.
Ya, Mas
Pak Irfan.
Ya,
Mas
terima
Krista,
kasih.
terima kasih.
Luar biasa.
Ya, Mas
terima
Widianto.
kasih, Bapak.
Ya, terima kasih, Pak.
Ya.
Mantap, Putu, sukses. Mbak Irma, terima kasih.
Semua berkat doa dan dukungan
Terima
Om.
kasih Pak
Thank you,
Sigit.
Pici.
Thank you, Pici.
Selamat.
Salamat po. Walang anuman. See you soonest, everyone. Keep safe.
Thank you.
Thank you.
Thank you for your hard work, Sir Putu.
Everyone.
Susan.
Thank you, Miss Yin Yin Tan.
Thank you. See you time. Bye-bye. Good night.
Good night.
Bye-bye, Yin.
Bye. Nanti pertanyaan dan jawaban akan kita share juga di grup Facebooknya Bu Irma.
Siap.
Thank you.
Baik, bagi Bapak Ibu yang tadi belum kita bahas pertanyaannya, nanti kita akan post semua pertanyaan dan jawaban di sosial media PARI ya, Beli ya?
Ya.
Ya, official sosial media PARI ya, Beli ya, bukan lain-lain ya. Jadi Instagram kita, apa ya Beli Instagram kita
Info
ya?
PARI.
Info PARI. Okay.
Kemudian yang nggak ada namanya nanti menyusul ya solusinya ya. Ya, mohon bersabar Bapak Ibu ya. Kemudian ini pendaftarnya 1180 yang di ruang Zoom sampai 660 Om ya. Itu sesuai dengan prediksi sebetulnya.
Iya, 50%.
Lebih dikit. Setengah penuh ya. Baik, untuk video akhir kami ada 2 video penutup. Yang pertama tentang Wonderful Indonesia dan himne PARI. Dengan berkumandangnya himne PARI, maka acara 16th CPD Asia juga akan selesai dan tutup. Demikian Om, ada yang ingin disampaikan lagi? Om sedikit? Bapak Sekum mungkin? Bapak Sekum lagi on the way tadi?
Ya, silakan dilanjut aja, Beli.
Baiklah, terima kasih Om Sigit. Pak Purwantono mungkin? Pak Purwantono, ini udah open speakernya. Ada Mas Irfan? Baik, saya akan ya mulai untuk last video. Oh.
Bali, a very rich land, blessed with an abundance of natural resources to be explored. No wonder Bali is so attractive, a magnet for thousands of souls. Coming to see firsthand its magical beauty that will never run out. An island of thousands of gods, radiating the high energy of its spiritual beliefs and holding them as a legacy of faith. A home where many outstanding works are born, diverse and majestic, with deeply meaningful significance. We commit to not using single-use plastic down to every local level, dedicating ourselves to being on the front lines of the fight for a plastic-free island. Establishing ecotourism services and applying green and renewable energy, equipped with solar panel technology in the interest of a clean and green Bali. Therefore, Bali will always preserve the beauty of this haven, being fully aware of and responsible for what the Most High has bestowed upon us. Protecting nature's most precious resource to support the community and all its activities. To be the wellspring of all of nature's splendor. So, this is Bali, a home to every smile, where we are reminded of being connected to God, others, and nature, so harmony and prosperity can be achieved. This is a place we adore. We love Bali.
Bagi
Izin and meeting for all.